Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Welcome, everybody. Hello, Christine. Welcome back.
Hi, Jeff. Happy to be back.
Nice to see everyone. It's been a few months, and we're very, very excited today to have with us Dr. Jaggi Rao, a dermatologist from Edmonton, dermatologist extraordinaire, certainly nationally renowned, internationally renowned. And we're going to talk today about rosacea. Always a mystery, isn't it, Christine?
Yeah, I think Dr. Rao, I have had the chance to work together in the past, and not only is he a dermatologist extraordinaire, but you really have your finger on the pulse of primary care and the ongoing confusion of the ubiquitous rash that comes in. Is it atopic dermatitis? Is it rosacea? Is it psoriasis? And in some cases,
Is it acne?
acne,
Right.
yeah. Maybe you could just start and just tell us what rosacea is, what it isn't, and how we differentiate it practically.
Absolutely. Well, thanks so much for having me on your show. I'm very honored and privileged to be here. Rosacea seems to be a condition of the vascular system of the skin, particularly of the face. So it's very different from other conditions. There's no oil glands that are directly involved. It's not really bacteria that's involved, but there is inflammation at times, and it's largely due to blood vessels and reactivity to blood vessels. So if I had to define rosacea, I'd say that it's an inherent condition where people have the tendency towards having sensitive blood vessels. What that means is that when your blood vessels encounter a trigger, whether that be internal or external, the triggers cause your blood vessels to become bigger. And when they become enlarged, then you have greater blood flow that causes heat, sometimes symptoms such as itch, sometimes burning sensation, and ultimately redness. And if you allow it to progress, you can even get bumps, inflammatory papules.
Okay, and in terms of distribution, I know you gave some tidbits when we were talking about where it occurs, where it doesn't occur.
You're saying more on the face, you were saying, right? So then the first conundrum we have is this person comes in and it looks like acne. How do we know it's not acne?
That's right. So sometimes the inflammatory rosacea can look exactly like acne because you have inflammatory papules, but there are a few distinguishing factors. Usually with rosacea, you'll have a preceding erythema for several years. So the redness of the skin on the cheeks, the forehead, the nose, and the chin will often be there. In rosacea, if you look really carefully, you can probably see some lines or broken blood vessels. The true term is telangiectasias. They're little blood vessels that have become enlarged. And typically we see that on the cheeks and around the nose and maybe the chin and forehead as well. We don't typically get that with acne. Acne also seems to be more prevalent in teenagehood, so adolescence, whereas rosacea happens a little bit later in life. You typically are 30s, 40s, and 50s is when we see it. And also with acne, if you look really closely, you might see some whiteheads and blackheads, which you don't see with rosacea. And I guess lastly is look at anatomic site. In addition to the face, acne can often happen on the chest and back.
And which we don't typically see rosacea on the chest and back.
That's right.
Right. Okay. So if we're seeing blackheads, we're probably not looking at rosacea.
That's right.
And just in terms of ethnicity and different types of skin, we live in a multicultural country, and sometimes I find it hard with people with different shades of darker skin to make those distinctions. Do you have any tips or?
Yeah, it is really hard, isn't it? If you have darker skin, sometimes the redness will be obscured by the pigmentation that's there. So there are a couple things you can look out for. One of them is the symptoms. So if people are having burning sensation and they're having a little bit of itch in certain areas like the nose and central cheeks, that might be indeed be rosacea. Look for those dilated blood vessels because you can see those and regardless of the background color of your skin. And then sometimes look for advanced forms of rosacea, such as what we call rhinophyma, where you have a bulbous nose, you have fibrosis, which is basically an undulation, a little bit of bumpiness on the nose, sometimes a lot. That's very typical.
W.C. Fields, right?
Absolutely. Yeah. They even said Bill Clinton, and you see other people with it too, but W.C. Fields is classic.
Does Bill Clinton actually have rhinophyma? That's interesting.
Yeah.
And with rhinophyma, there's a definitely correlation with alcohol, right?
Well, I think alcohol is a very big trigger for rosacea in general. So it's often associated with rhinophyma. And the fact is, it's more common in men for several reasons. Men have a more extreme response, but also men sometimes present very late. And so it has that old connotation, but I don't know if that's true. So we have several people who have alcohol syndrome and they don't have rosacea at all. And other people who have very bad rhinophyma, and they haven't sipped alcohol a day in their life.
That brings us to it's a good segue into assumptions that are made when a patient comes in with any sort of rash. But I think they've done quite a bit of research on rosacea, on quality of life and social impact. Do you want to make a comment about that? I find it to be fascinating.
Yeah, there's quite a bit of stigma with rosacea, particularly if you can see the redness and the flush. And especially for younger people, we see that to be true. And if you have it, if you're cursed with having this earlier in life, it can sometimes even change your path of life because it leads sometimes to self-depreciation, depression, anxiety. It can even change your course of vocation in some types. It affects relationships. Self-worth is decreased with rosacea in general. So for sure, just because it's so visual on the face.
And, I think then that stigma too sort of perhaps keeps people away from even asking for help because they're so ashamed. But I have to remind myself that sometimes opening up the discussion really leads the way to a patient feeling that they have an opportunity to talk about their rosacea. So treatment options, high level and some new players.
That's right. So I guess it depends on the type of rosacea they have. If it's just redness, if the skin is generally pretty flat and smooth, then really it's just going to be trying to reduce the size of those blood vessels and the reactivity of the blood vessels. And I find that the topical and oral agents really don't work that well. It's more of what I jokingly call a plumbing issue. The pipes are a little bit enlarged and we need to kind of make them smaller and more stable. And I find what works really well is laser therapy or some type of energy-based therapy that can reduce the size of the vessels. And then once, if you do happen to have inflammatory rosacea with pimples and sometimes pustules, then the medications seem to work really well, particularly topical medications to start, and sometimes even oral anti-inflammatories.
Like topical, what would you start with?
So there's a number of different things. I mean, traditionally, we used to use antibiotics topically that would have anti-inflammatory potential. For example, metronidazole in cream form used to be the way to go. The problem is because it's an antibiotic, we find that there's resistance to it over time. So we've used it for more than 50 years and now it's just not working as well. There's another agent called Rosivir, which is topical ivermectin, and it works in a number of different ways. It reduces inflammation directly, and it might even reduce some of the internal triggers of the skin that are causing the inflammation. For example, little microscopic mites and other organisms. It has a potential to reduce those. So this is called Rosivir. And now we're taking a look at benzoyl peroxide. So benzoyl peroxide, especially if it's in a micronized format, it's not as irritating to the skin. And in fact, it can be quite soothing to the skin, has the ability to also reduce the inflammation.
Just benzoyl peroxide or mixed with something?
I would recommend just benzoyl peroxide, but ensure that it's micronized. If it's not micronized, it can irritate the skin quite a bit, regardless of whether it's mixed or not.
Okay, that's interesting.
Yeah, I mean, it's back. I think it generally got a bad reputation initially, but it's the encapsulation that will make the difference, which is a huge game changer. And so even moving even backwards, any suggestions you make about avoiding any types of irritants, sunlight, SPF protection? What are some basic lifestyle things? Because patients need to know that, and they often have very specific questions.
Yeah, absolutely, Christine. There's a few triggers that seem to be true across the board, regardless of who you are. The number one trigger is that of sunlight. And whether it's actually ultraviolet light or is it high intensity visible light, we're not really sure. Maybe it's both. Perhaps it's even the heat from the light, the infrared radiation. But sunlight seems to be a trigger in more than 80% of individuals. So sun avoidance is ideal if you have really severe rosacea. And for sure, sun protection in some way, wearing hats and just protective clothing. If you can wear even opaque type of sunscreen that's supposed to be a little bit better than some of the absorbent sunscreens that are chemical based. The other thing is going to be certain foods. So we talked a little bit about alcohol and caffeine, maybe, which causes vascular dilatation. That seems to be a trigger for a lot of people. Coffee and teas and even chocolate for a lot of people, they tend to flare. That seems to be number 2 and 3 on the list. And then going further down, it'll be very individualized. For example, certain types of moisturizers and even cleansers can set it off. So people have to individualize it, I think, and just try to identify and avoid those.
And then the topicals don't work, or they don't work as well as we want, and we typically move on. I mean, I've tried low-dose doxy, and I find it works very, very well, like Aprilon. What's your feeling?
Yeah, I agree with you. I think that oral medications definitely work better in general than the topicals, although that new benzoyl peroxide seems to be very promising as a standalone. It's called Epsilay, and I would start off with that. And then if you need to, then you can add something to it. Doxycycline is by far the favorite amongst dermatologists, and it comes in 2 doses. We have the low dose doxycycline, which is Aprilon. It's 40 milligrams a day. And we also have 100 to 200 milligrams of doxycycline, just a doxycycline by itself, hydrochloride, which is pretty good too.
And would you start with high-dose doxy and then go down to low, or you just go right to low?
Generally, I go to 100 milligrams QHS, but you could go to Aprilon as well. It's just a question of coverage. Some of them may not have coverage for that 40 milligram dose. 100 milligram is a little bit more easily covered, I think, across the board.
But are you worried about resistance with the 100 if you use it long-term?
Yeah, that's a really good point. I mean, as I mentioned, we saw that with the topical metronidazole, and we probably will see that with doxycycline if we overuse it. However, we discovered if you go to lower dose doxycycline at the 40 milligrams, it's below that threshold where these bugs can develop resistance. So I agree with you.
Okay, and if you have to use the 100, how long are you comfortable leaving them on it?
Yeah, so generally we do it until the bumps have cleared. The expectation for the redness to clear on that is not going to happen. That's overly expectant, I think. We do it for about 2-month increments is what I do, so intervals. So 2 months of doxycycline and then review. If the patient's bumps are under control, then you can stop, maybe switch to a topical.
And for how long would you keep? So if you're starting the 40 milligrams, same goal and then pulse it, or?
Yeah, that's a good point. Yeah, so what I would do is I do the 40 milligrams once a day, and I would do it for 8 weeks, which is 2 months, and then review. And if they need it again, you go another 2 months. And if they need it one more time, then you go a third interval of 2 months for a total of 6 months. If it's not worked within 6 months to reduce the inflammation, then I think you either refer to a dermatologist or consider other options. One option that we would do if a patient was sent to me in that scenario is I'd consider isotretinoin. So Accutane, Epuris, Claris, Absorica LD, that seems to work very, very well.
Even in rosacea, that's interesting.
Yeah, even in rosacea, of course, it causes a little bit of dryness, but once we address that, you can actually bring down those bumps.
Wow, that's interesting. And you were talking about laser before. That's more for the erythema, right?
That's right. Yeah, and actually more than just that. What I typically do is once a person's inflammation is under control, then you might want to consider laser for prevention. And the thought is that in addition to preventing the erythema, it might even prevent further inflammation in the future.
Wow. And what about if they're starting to get early rhinophyma? What do you do?
Right. So rhinophyma usually happens on the nose, as we mentioned, but you can get phymas on the eyebrows, sometimes even on the ears, believe it or not. But the nose will usually present first, and usually in males. And sometimes it'll be associated with a little bit of discharge, this cheesy white discharge. If they squeeze their nose or blow their nose, you'll get this material coming out, sometimes accompanied with oil. So the first thing I do is dry out the skin. That involves phase 1 is isotretinoin. So I put them on Accutane or Epuris, 40 milligrams a day for about 8 weeks should be enough. And once that's completely dried out, the next step would be laser. So first step is to dry it out. Second step would be laser therapy. But different from the vascular laser that you'd use for erythema, this would be laser resurfacing to kind of even out the skin, to make the skin a lot tighter.
And for people with those severe rhinophymas, can you actually remodel it to look back to normal completely?
Yes, actually, surprisingly, you can. If you send them to an expert laser surgeon, what we typically will do is we'll use a combination of laser plus electrocautery. So we will use bipolar electrocautery to literally shave off pieces of skin. So sometimes people get these gross deformities of fibrosis. You can actually take those off. Sometimes we use a bit of a blade as well. So we do coarse debulking, and then you do finer debulking and ultimately smoothing with a laser.
And you mentioned that rosacea doesn't involve the glands, but what is this discharge from the nose then?
Yeah, it doesn't directly involve the glands, but I think what's happening is when you have inflammation there, the white blood cells, particularly neutrophils, they contain different types of peroxides that injure the skin. And then you have almost like a scar-like response. You have fibrosis that's there, and that compresses the glands that are already there. So when you have that, it can even encourage a little bit of keratin buildup, which is white material, the cheesy material that you sometimes will get within whiteheads and blackheads. All of that will build up along with some oil.
What about the dreaded ocular rosacea?
That's right. So there is a type of rosacea called ocular rosacea. Sometimes it's misdiagnosed because it might just have symptoms. And typically people will have like an irritation of their eyes and lining of their eyes. Sometimes you'll have corneal injection. The eyes will be red. Sometimes a bit of a grittiness feeling. And even you'll get even a clogging of some of the tear ducts because of dead skin material. It's believed to be rosacea from the skin, so from the facial skin that is basically coming in from the outside and affecting the lining of the eyes. So the conjunctiva and the apparatus around the eyes is being involved. There's quite a bit of inflammation. It's really challenging to treat. I know a lot of optometrists and ophthalmologists, they don't like seeing this because they don't have a good solution. This is where we would consider treating the rosacea around the eyes first, and then often the ocular rosacea will improve itself. And then symptomatically with different types of eye drops that can, gentle cleansers, different types of lubricants, these can help to make people feel better while the rosacea is being treated.
Okay, that's very, very helpful. Christine, any other comments, questions?
No, I mean, there's just such a gamut of options to treat patients. I guess my one question is, what do you see family doctors miss or incorrectly do?
That's a good question. I think the biggest thing is diagnosis. If they can somehow get to it earlier, it'll be easier to treat. And as you correctly said, people often don't present with it because it's considered a stigma and it may not be pressing at the time because it's so fluctuant. But if you can catch it early and you identify it, then you start treatment. And that would be laser therapy is still ideal if it's just flat. But then if it's you're getting any types of bumps, even the smallest inflammatory papules, you would want to treat it. I think this Epsilay is a good choice only because if you're not sure if it's acne or rosacea, Epsilay will actually help both.
Yeah, it'll work for both.
Yeah, although it's officially indicated for rosacea, it would really help for acne too. And then if you needed to, then refer early.
And that central facial redness is a good diagnostic giveaway, right?
Absolutely. Yeah, there is another form of redness that is often confused for acne called keratosis pilaris. So KP or keratosis pilaris is very common on the upper outer arms.
I would see that on the arms of kids.
That's right. You get a red bumps and you get sometimes a little bit of roughness that's there, but it can also happen on the cheeks. And we see it with kids who are adolescent or even pre-adolescent, and they can get quite red and flushed, and it's often confused for rosacea, but it's not rosacea. The typical treatments for rosacea won't work. This is considered to be a form of eczema. And so really what I would do is moisturize the skin, make sure that it's nicely hydrated. Can I suggest something? I suggest a little bit of salicylic acid with a bit of a moisturizer. A good choice would be CeraVe SA lotion, which is over the counter. Sometimes I'll even put a little bit of hydrocortisone there, 2.5% HC, hydrocortisone powder in CeraVe SA.
Okay, so the CeraVe SA has sal acid in it.
That's right. Yeah. And it'll smoothen the skin.
And it's over the counter.
Over the counter.
So when you have the hydrocortisone, you get them to mix it themselves?
No, I get the pharmacy to mix it.
Okay.
And sometimes it may even be covered for them, depending on their plan.
Yeah, so you'll mix 2.5% powder into the CeraVe SA.
That's right. And then they can apply it once or twice a day. And even the upper outer arms, it's good. And you'll see that it'll improve. It'll smoothen the skin and maybe even reduce the redness.
That's amazing. All right, Jaggi, thank you. That was a phenomenal overview of rosacea, and thank you for the pearls.
Oh, it's my pleasure.
My only complaint is that you're not in Ontario and I can't make timely referrals.
You're always welcome. Thank you.